Ladies and gentlemen, it is my big pleasure to be here to open the session on heart failure in 25th Asian Federation of Cardiology Congress. I would like kindly to let you know that this is European Society of Cardiology and Asian Federation of Cardiology joint session. I would like first to thank Professor Michael Komajida to put this important and very interesting session together. We are going to discuss several important topics because we all know that heart failure is now one of the very hot topics in the field of cardiology. Many new things happened, new therapeutic activities and new therapeutic strategies are emerging, and we are going to discuss some of them now. I would like also to let you know that I'm chairing this session with Azmee Ghazi from Malaysia. My name is Petar Seferovic. I am originating from Serbia. I live in Serbia, but I am also the Vice President of the European Society of Cardiology, and it is my big pleasure, let me say once again, to be here. I would like now to ask my co-chairman, Azmee Ghazi, to address you. Azmee, please.
Thank you very much, Professor. I think welcome again, everyone, to the Asian Federation of Cardiology and the European Society of Cardiology joint session. And as what Professor has mentioned, we are focusing on the heart failure update. My name is Azmee. I'm from the National Heart Institute in Malaysia, Kuala Lumpur. So we've had many recent developments with regards to managing heart failure, both pharmacological and also intervention. I think, and this has led to very few recent updates in the clinical guidelines worldwide. And without further ado, I would like to invite our first speaker, which is Professor Petar Seferovic, who is the Vice President of European Society of Cardiology and the immediate past president of the Heart Failure Association of ESC. He's a professor at the University of Belgrade Faculty of Medicine and also an academician of the Serbian Academy of Sciences and Arts and president of the Heart Failure Society of Serbia. And I think with that, I would like to invite Professor. He will be presenting to us what is new in 2021 heart failure guidelines. Professor, all to you.
Thank you very much, Azmee. Before, I would like to thank you that heart failure has a big tradition, and it is my great pleasure to have Michael Komajida, one of the gurus of heart failure with us, who is practically was very instrumental in putting several of the important heart failure treatment options. Having him in our session gives us a lot of confidence that we are going to have an excellent event here. What I'm showing now is the first edition of the Heart Failure Association Atlas, which Heart Failure Association of the ESC put together. And this is important because that's the first time in the history of ESC that we have some ideas about the incidence and prevalence on heart failure in Europe, which was given by the different heart failure national societies. As you see, the incidence and the prevalence of heart failure are quite high, giving us the idea that we are dealing with one of the major threats of the humanity. Even we have a good and excellent treatment options, we may say that the residual risk of cardiovascular death in heart failure patient in both HFrEF and HFpEF remains here, and despite receiving the standard of care of this patient, we decided to working relentlessly on finding the new therapeutic options. So what was new in the new 2021 long-awaited guidelines? The diagnosis and treatment of acute heart failure. And as you can see, there are several important new options. I would like to concentrate, since this is a 100 pages document, on something which will transfer the therapeutic message to our viewers. First of all, we know that there are 5 detrimental pathways in HFpEF, and blocking these pathways is essential. We have obviously major drugs, which are ACE inhibitors, or ARNIs, beta blockers, MRI, and newly introduced SGLT2 inhibitors. However, we have other drugs which are also very important, and they should find their own niche, how and when they should be used. To start with the novelties and to start with the new strategies, we may say that there are 3 important underlines in the ESC guidelines 2021 for treatment of heart failure. First, we use quadruple instead of triple therapy. Our approach is to have a simultaneous instead of sequential introduction of the drug, which is completely new. And also we have so-called patient profiling, which is basically the strategic phenotyping of our heart failure patients, giving us the possibility to introduce the precision medicine in heart failure. And as you can see, this is the general therapeutic algorithm in 2021 guidelines for heart failure. As we see, ACE, beta blockers, MRI, and SGLT2 inhibitors are class 1 level of evidence A, but also if the patient is congested, we are using loop diuretics. If this goes well, we don't need to proceed, but if the ejection fraction is still below 35 and patient is symptomatic, we may proceed with the use of devices, ICD on CRT-D or CRT-P. This is one of the most important tables of guidelines, which is representing the pharmacological treatment. 3 major drugs, ACE inhibitors, beta blockers, MRIs, and SGLT2 inhibitors with level of evidence A and the class of evidence 1. Sacubitril valsartan is recommended as a replacement of an ARNI, of an ACE inhibitors in patient with HFrEF with the class of evidence 1 and level of evidence B. So this is the basic of our treatment. And we understand that these new drugs should be introduced on not sequential, but on the continuous way. And let's look at the sacubitril valsartan, very important and very efficient drug. It reduces cardiovascular death or heart failure hospitalization in the patient with HFrEF, and that was confirmed in paradigm HF when sacubitril valsartan was compared with enalapril. However, the major breakthrough was started with SGLT2 inhibitors, and these are drugs which came from anti-diabetic field, and they came to the cardiology, to the heart failure with amazing cardiovascular outcome reduction effect, but also with the functional capacity improving in our patient. I don't want to spend too much time on the mechanism of effect of those drugs, but what should be said is that they are reducing intravascular volume, they are reducing preload and also afterload. They have a significant effect on the kidney with the effect on afferent and efferent glomerular arteriolar rate. So Heart Failure Association of the ESC was the first one to recognize that SGLT2 inhibitors will be much more than glycemic drugs, and we actually started to point it out that this drug may be extremely important in the treatment of heart failure without diabetes. And that was proven to be true because in one of the big controlled randomized trial, emperor-reduced SGLT2 inhibitors were shown to reduce heart failure hospitalization as well as cardiovascular death, in addition to the improving composite renal outcome with excellent hazard ratio and excellent absolute and relative risk reduction. That was also shown besides empagliflozin with dapagliflozin in DAPA-HF trial, in whom cardiovascular mortality, heart failure hospitalization, and urgent heart failure visit were significantly reduced in comparison with placebo. However, ladies and gentlemen, we should not forget the important but very old drug, the diuretic. And this is another Heart Failure Association paper in whom we detailed the use of this important drug for our general physician and our postdoc students. Diuretics are indicated in the patient who are congested and are providing a very significant risk reduction. Obviously, there are some other drugs which are important. One of them are ivabradine, which is causing heart rate reduction by inhibition of IF channels, reducing the diastolic depolarization slope and causing the lowering of the heart rate. As we all know, heart rate is an important risk factor, and it is for us essential to reduce heart risk in the patient who did not react properly, meaning they still have heart rate more than 70 under the influence of beta blockers. And in those patients, ivabradine is very much indicated. In these guidelines, ivabradine was given class of evidence 2A with levels of evidence B, so also very important drug. However, if we go further and look beyond first four important drugs, we can find a variety of the drugs and devices which can be given to selected group of patients to reduce heart failure hospitalization and mortality. In addition, if we look at the selected advanced heart failure patient, we can use some other important treatment modalities like heart transplantation, then left ventricular assist device. This is probably one of the major achievements in the guidelines, and this is patient profiling. To make the long story short, having four major drugs, we are dividing the patient according to the degree of heart rate, blood pressure, presence of absence of atrial fibrillation, and presence of absence of CKD. And then we can introduce some new and some additional drugs in those patients without giving them too much drug, and having in mind that drug which are given is indicated in those specific patient and can provide the better, not only immediate clinical effect, but also very good cardiovascular outcome. There are some other drugs which are given to the patient in advanced heart failure. These are soluble guanylate cyclase receptor stimulator, and this is one of the drugs in end-stage heart failure. Vericiguat was shown to reduce cardiovascular death and heart failure hospitalization in the group of almost 5,000 patients with a follow-up of 10.8 months and with excellent number needed to treat. So vericiguat is one of the options we can use in this group of patients with advanced heart failure. However, another galactic HF trial in whom omecamtiv mecarbil was investigated, did not show any positive effect of omecamtiv mecarbil on the composite outcome of the heart failure events and cardiovascular death. These drugs is not approved for the treatment of heart failure, but it seems that there will be some subgroups of the patient whom omecamtiv mecarbil can be successfully used. It is important for us to understand that this new treatment is giving us the possibility to not only giving the functional better feeling to our patient, but also to improve significantly the longevity of those patients. And according to the cross-trial analysis of Emphasis HF, Paradigm HF, and APA HF, this new treatment, comprehensive treatment, can prolong the life of our patient for 14.7 years. We call comprehensive therapy the use of ARNI, beta blocker, MRI, and SGLT2 inhibitors. Comparing to conventional therapy, this new therapy can give a difference of 8.3 years of longevity in our heart failure patient, very significantly, although this is a mathematical gymnastics, it is very important. In addition to that, although in the new guidelines, there was nothing about the treatment of HFpEF, and Professor Komajida will address this question, I would like to say that all of us were amazed with the Emperor Preserved study, in whom, for the first time in history, the drug empagliflozin showed a positive effect on the primary outcome of the first hospitalization and cardiovascular death. That was a sensational introduction which comes like 3 days after the guidelines were introduced. However, it is important to understand that the treatment of heart failure is always holistic and multidisciplinary. And this table illustrates that very well. So we actually recommending to our patient to use multidisciplinary heart failure management, to approach with the self-management strategies, and then also the home-based or clinical-based program are all very important with a class of evidence, one level of evidence A in our heart failure patients. In addition to that, one of the new, not so new, but very much approved approach is now the recommendation of exercise for the patient who are able to do it, and which is clearly improve exercise capacity, quality of life, and reduce heart failure hospitalization. Ladies and gentlemen, I think that we are now in the phase that we are absolutely faced with the new treatment modalities, with the new approaches in heart failure. And I think that all that at the end will help us to make our patient live longer and better. I would like to thank you very much for your attention. Okay, now we should continue. We should continue with our session. And it is my great pleasure to introduce Professor Michel Komajida, the past president of the European Society of Cardiology and one of the leading experts in the field of heart failure, who is going to discuss one of the most challenging topics in heart failure, and this is heart failure with preserved ejection fraction. Where do we stand now? Professor Komajida, please.
Good afternoon, ladies and gentlemen. It's my pleasure to review with you today the very challenging condition, which is heart failure with preserved ejection fraction. This is my disclosure slide, and I will review during this 15 minutes the pathophysiology, the diagnosis, the epidemiology, the clinical profile, and the prognosis together with the treatment of heart failure with preserved ejection fraction. What we are talking about is the condition which is shown at the bottom part of this slide, which used to be called diastolic heart failure. On the left-hand panel, you have an anatomic slide, and on the right-hand panel, you have an echocardiographic slide. And you see that, as observed in most instances in HFpEF, there is a marked left ventricular hypertrophy, and the cavity of the left ventricle is markedly reduced as well. There are three main abnormalities regarding the pathophysiology of HFpEF. One is a delayed relaxation with an increase in the tau. The second one is an increased stiffness of the left ventricular chamber, which results in an increase in diastolic pressure. And these two abnormalities are the result of the change in the content of the myocardium. This is an electronic microscopy of the myocardium. On top is shown a normal myocardium, and on the bottom part, an HFpEF patient. And you can see here that the collagen fibers are markedly thickened in HFpEF, and they are more intertwined one with the other. And this is the explanation for the stiffness of the left ventricle. But there is a third abnormality which lies in the great vessels, which is a decrease in aortic distensibility. As shown here, you have on the left-hand panel healthy young people, on the middle panel healthy old people, and on the right-hand panel diastolic heart failure or HFpEF, and you can see that the distensibility of the aorta is markedly reduced in this condition, which creates a mismatch between the left ventricle and the aorta. This is a summary of the necessary items to diagnose HFpEF, and this comes from the latest guidelines of the European Society of Cardiology. HFpEF requires that patients have symptoms and or signs of heart failure, an ejection fraction of at least 50%, but this is not sufficient, and we need to show objective evidence of cardiac structural and or functional abnormalities, which are the proof of the existence of left ventricular diastolic dysfunction or raised left ventricular filling pressures, and this includes the use of natriuretic peptides. You should not expect that all criteria, which I will review in a second, should be present in all patients. And I take the example of left atrial enlargement, which is a rather sensitive clue of the presence of HFpEF. This is a sub-study from the I-PRESERVE trial, and you can see that in this trial, we observed that in one patient in 3, there was no left atrial dilation. However, at least one criterion on echocardiography is present in nearly all patients. This is a flowchart which has been released by the European Society of Cardiology to help for the diagnosis of HFpEF. It uses clinical assessment and standard diagnostic tests, including natriuretic peptides, electrocardiogram, X-ray, and echocardiography. If these criteria show a high probability of HFpEF, it is considered that the diagnosis is confirmed. If it is low, we should look for other causes, non-cardiac causes. And in the intermediate cases, we should move to more sophisticated tests, including diastolic stress test on echocardiography at rest or on exercise, or in a few cases, invasive hemodynamic studies. These are the criteria which the ESC recommends. In pink are shown the major criteria. In yellow, the minor criteria. Major criterion makes 2 points, minor criterion makes 1 point. And we consider that if the total number of the points is at least 5, the diagnosis is confirmed. I will not detail all these criteria, but as you can see, they include the presence of left atrial enlargement, left ventricular hypertrophy, the E/E' ratio, and the level of natriuretic peptides, in the two conditions, sinus rhythm or atrial fibrillation. What is the prevalence of HFpEF? This is a summary of some important cohorts, and you can see that it varies from one registry to the other, but in most instances, it represents at least 40% of the overall heart failure population, and it is rising because of the aging of heart failure patients. And this is particularly true in elderly people. This is a sub-study that we did out of the Euro Heart Failure Survey 1 more than 15 years ago. And you can see that in orange, patients with an ejection fraction, patients who are octogenarians in yellow have a higher likelihood of having HFpEF than patients who are younger. What is the clinical profile of patients with HFpEF? This is a large consortium called MAGIC, which pooled a number of studies of patients with HFpEF or HFrEF. And you can see that there are some marked differences between HFpEF and heart failure with reduced ejection fraction. The age is older, 71 compared to 66. The proportion of women is approximately half compared to only 1/4 in HFrEF. And the medical history is also different, with a much higher prevalence of hypertension or a myocardial infarction than in HFrEF. Also, the mortality rate is higher in HFrEF from what it is in HFpEF. This is again data coming from the MAGIC consortium, and you can see that the risk of dying in these patients with HFpEF was approximately reduced by 30% compared to those with HFrEF, although the absolute rate of death remains high with nearly 20 or 25% at 3 years. And this is the result of the fact that the overall mortality rate declines when ejection fraction goes up, but the proportion of non-cardiovascular deaths, which is shown in black in these bars, remains rather stable. So there is an important observation, which is that the rate of non-cardiovascular deaths is higher in HFpEF than what is observed in HFrEF. How are these patients with HFpEF treated? Our guidelines state that there is no evidence for treatment showing consistently a reduction in mortality in these patients, although there is novelty here, and I will come back to that in a minute. On average, patients with HFpEF, this is again data from MAGIC, are less likely to be treated by ACE inhibitors or ARBs, by beta blockers or spironolactone together with digoxin. Actually, most of these patients are treated for the underlying disease, which is in most instances, as I said, hypertension. This is a summary of 4 important clinical outcome trials, which all failed to show a benefit in this condition. Top left is the CHARM Preserve trial with candesartan. It was negative on the primary outcome. On top right is the PEP-CHF with the ACE inhibitor perindopril, also negative. Bottom left, iPreserve with irbesartan, also negative. And bottom right, TopCat with spironolactone, no significant benefit with these patients. However, in 2 of these trials, CHARM Preserved and TopCat, there was a significant reduction in a secondary outcome, which was heart failure hospitalization. 2 years ago, the Paragon heart failure trial was presented at the ESC annual meeting, and it was a comparison of sacubitril valsartan titrated up to 200 milligrams twice daily versus valsartan given at a high dose of 320 milligrams per day. The primary outcome was a composite of the total, including the first and recurrent heart failure hospitalizations and cardiovascular deaths. and the average follow-up was approximately 35 months. Unfortunately, this trial fell short of showing benefit on the primary outcome. You see that there is a trend for a benefit in patients treated by sacubitril/valsartan, but this did not reach significant level. And when you look at the two components of the primary outcome, most of the benefit, if ever, was related to heart failure hospitalizations on the left-hand panel, whereas cardiovascular mortality remained unchanged. Interestingly, in this trial, there was a subgroup analysis which showed that female patients tended to have a benefit, whereas male patients did not. And also patients with an ejection fraction below 57% had a benefit compared to those above the median, which were 57 in this trial. And very recently, at the last ESC annual meeting, there was a landmark trial which was presented and which shows a change in how we could treat this heart failure with preserved ejection fraction. It is the Emperor Preserve study, and the design is shown here. It's a comparison of the sodium glucose cotransporter 2 inhibitor empagliflozin, 10 milligrams once daily, compared to standard of care, with a median follow-up of 26 months. As you can know, empagliflozin has been primarily used in diabetes mellitus, but in Emperor Preserved, only half of the patients had diabetes mellitus, and the other half had not. It was a large trial, nearly 6,000 patients, with an ejection fraction of at least 40%, and the primary composite endpoint was time to the first event, either cardiovascular death or heart failure hospitalization. These are the demographic baseline characteristics. You can see that this is a population which is very similar to what we see in HFpEF. 45% of women, mean age was 72 years, and the ejection fraction was 54%. Interestingly, these patients were well treated in terms of RAS inhibitors or ARNI, MRAs, beta blockers, and statins. And this is the primary outcome. So this is the first trial showing a significant benefit in HFpEF in favor of empagliflozin, with a relative risk reduction of 21% on the primary outcome. And as you can see, the two curves diverge very early, so it seems that the benefit occurs very early on in patients receiving empagliflozin compared to placebo. When you look at the two components of the primary outcome, once again, it seems that the benefit is greater for the first heart failure hospitalization than for cardiovascular death. But anyway, the composite endpoint was once again significantly reduced in patients treated by empagliflozin. There were important subgroup analyses performed in this trial, and you can see that the presence of diabetes did not change the benefit. So it's very similar in diabetic and non-diabetic patients. Again, sex did not change the result of the trial, unlike what I just mentioned for Paragon heart failure. Male and female subjects had a similar benefit. And finally, ejection fraction, there was no trend for a significant difference, although numerically, the benefit seems to go down when ejection fraction goes up. So in summary, Emperor Preserve showed a significant reduction in the primary composite of 21%. The first secondary endpoint, which was the total number of heart failure hospitalizations, was also reduced by 27%. And the second important secondary endpoint, which was the slope of the decline of the glomerular filtration rate, was also significantly reduced. So in terms of adverse events, you see that the number of serious adverse events was more or less similar in the two arms. There was a numeric increase in the rate of hypotension and of symptomatic hypotension, but there was very little difference. And the only difference was a side effect which has been already described with SGLT2 inhibitors, which was a higher rate of genital infections. But taking all in all, I think that the Emperor Preserved is the very first trial to show any benefit on heart clinical outcomes in heart failure with preserved ejection fraction. So I would like to conclude my lecture by the following points. Heart failure with preserved ejection fraction remains a dilemma for clinicians, and the diagnosis is challenging. As you saw, we need to have a combination of clinical signs and symptoms, echocardiographic features, and natriuretic peptides. Until recently, management of this condition was not evidence-based, and several clinical trials failed to show a convincing improvement in clinical outcomes, but very recently, Emperor Preserved showed that empagliflozin reduces the composite of cardiovascular death or heart failure hospitalization in this condition. Thank you very much for your attention.
Thank you very much,
Azmee,
Prof.
please.
Komaja. Yeah, thank you very much, Prof. Komaja. I think an excellent presentation again. I think, we'll probably have some questions at the end and discussion at the end of this session. But moving forward, I think, I would like to invite our third speaker, Dr. Hawani Sasmaya. She's a consultant cardiologist in Heart Failure Division and the Department of Cardiology and Vascular Medicine, Faculty of Medicine in Panjaran University Hassan Sadikin General Hospital in Bandung, Indonesia. And she'll be presenting to us on risk scores in heart failure. Are they useful? Dr. Sasmaya?
Thank you, Chairman. Good afternoon, dear colleague. Thank you, AFCC committee, for the opportunity. Today, we will discuss about risk scores in heart failure. With the title of my presentations is risk scores in heart failure, are they useful? I have no disclosure. Until now, heart failure still become one of the major issues worldwide. There are 64 million heart failure patients, and this number is still growing and is predicted to increase up to 2 million heart failure patients in 2030. As we know, heart failure treatments has developing so fast. There are many new promising treatment and devices. However, the mortality number is still high, even higher than prostate cancer in male and breast cancer in women. Thus, it is crucial for clinicians to have a strong and accurate heart failure outcome predictions, which is important to help clinicians come to decisions for their patients' management, especially if it's related to diagnostic or therapeutic interventions, as we don't want to put our patients on risk without any benefits. Heart failure risk scores are divided into two groups. The first one is risk score for chronic heart failure, either heart failure reduced ejection fractions or heart failure with preserved ejection fractions, and also risk score for acute heart failure setting. Today, we will discuss more about risk scores in chronic heart failure. Start with HFSS. This scoring system was dedicated for heart failure reduced ejection fractions, but hardly used due to its difficult to implement, as we need VO2 max, which is not widely available, especially in Indonesia. And then CHARM was generally used, but the limitations is this scoring system didn't include systematic measurements of blood tests, for which we know certain blood tests are important predictor of heart failure outcome. And continue with the other two most commonly used risk score in heart failure, which is Seattle HF and also MAGIC risk score. These two scoring systems include not only clinical parameter, but also laboratory and heart failure treatment. However, either Seattle or MAGIC risk score have not added biomarker tests. Hence, to increase the accuracy in predicting prognosis, there are two more recent scoring systems, the Predict HF and also BCN Bio HF, that included biomarkers, which we will discuss later on. Here are all the Seattle and also MAGIC variables. There are many variables that we need to calculate, but both of these scoring systems have an automatic calculator that can easily download it. As I already mentioned before, there are two scoring systems that included biomarker. The first one is the PREDICT-HF score. So by adding NT-proBNP, it increased the accuracy in predicting heart failure outcome. As what we can see in here, PREDICT-HF has a good ability to differentiate cardiovascular death and heart failure hospitalization risk, and also all-cause mortality. Similar with the PREDICT-HF, in the BCN Bio-HF scoring system, also included biomarkers, and not only they added NT-proBNP, but also high sensitivity troponin and soluble ST2 as well. Therefore, this scoring system has an excellent accuracy in predicting risk of mortality in heart failure patients. And based on the study that performed head-to-head comparisons, a risk score in heart failure, this study showed that none of the available risk score is superior, but BCN Bio-HF at least show a good discriminations and overall performance. However, the limitations is the results tend to be overestimated. What we can conclude from this study, actually, that biomarker has a crucial role to refine risk of death in heart failure patients. Hence, we need to routinely use biomarker, especially NT-proBNP, in predicting outcome for heart failure patients. And here is the most recent scoring system that developed based on Emperor-reduced trial. We know that all subjects included in this study have received comprehensive optimal medical treatment, which describe more of the current situations in heart failure treatment. So then the next questions will be, should we perform one of these risk score in our daily practice? Data showed that most clinicians not routinely use risk score in their heart failure patients. There are many reasons, including most of the risk score didn't help much in making day-to-day practice decisions, and also real-world heart failure populations tend to be older and more complicated than RCT, as we know that most of the heart failure risks were developed based on RCT study, and they not included non-fatal events, which are important for patients' quality of life. Therefore, physicians until now are reluctant to use heart failure risk score in daily practice. And one of the study also showed that the conventional heart failure risk score, including MAGIC, CHARM, GC, or Seattle, tend to be over predictions. This is more likely due to there are significant improvement in heart failure treatment nowadays. And this conventional risk scores developed in the early year, which the heart failure treatment was still limited at that time. Luckily, there are two most recent heart failure risk score that updated based on the latest treatment, because we know that heart failure treatment evolve over time. This updated scoring system, either PREDICT-HF and Emperor-reduced, may provide us a precise predictions of heart failure outcome and avoid over or underestimate risk. The PREDICT-HF risk score was developed based on a PARADIGM-HF study, which we know that all subjects included in this study were on optimized medical treatment, although only few patients on ICD or CRT. Here are all the variables that we need to calculate but now the automatic calculator system has available online. These PARADIGM-HF models can accurately predict heart failure hospitalizations and also cardiovascular mortality in ambulatory chronic heart failure at 1 and 2 years. But however, this risk score only limited for heart failure reduced ejection fractions and less evidence in patients with devices either ICD or CRT. This scoring system also included NT-proBNP, which we know it will increase the accuracy in predicting heart failure outcome. The other most recent scoring system is developed based on Emperor-reduced trial. This scoring system has generated specific cardiac biomarker, both NT-proBNP and also HS troponin. And as we know, this RCT included patients with most recent heart failure treatment, including ARNI. Thus, maybe this scoring system can fulfill the gap evidence of novel heart failure risk score. This scoring system also helps clinicians to define patients that will get more benefit by adding SGLT2 inhibitor, as we can see in here. Although empagliflozin has a significant impact in improving heart failure outcome in all subjects, but low risk group has shown more marked risk of reductions. So if we go back to the question, should we perform risk score in heart failure in our daily practice? The answer should be yes, considering it's useful because in heart failure populations, risk prediction is more challenging. Many factors affected, not just as simple as younger patients tend to have a better prognosis than older patients. And predicting likelihood of heart failure outcome is valuable in selecting patients' appropriateness for certain therapies, such as certain devices. We know that we wouldn't put our patients on ICD if the life expectancy will be less than 1 year. And it can also help patients and their families plan for the future. But the most important is, It's not a final sentence. It may change by time. Knowledge of prognosis is essential for planning our patient's management for an optimal patient's care, and it should not replace the doctor and patient's discussions regarding patient's treatment plan. It's more just to inform the patient's risk. So we still need to discuss with our patients about the treatment plan. And actually, most of the time, clinicians frequently use functional class and also ejection fractions to predict heart failure patients' outcome because it's easy to do. Yes, it's undebatable that patients with NYHA class 3 or 4 likely have a higher risk of death, but we tend to forget that the risk of death will be still high for patients with NYHA class 1 or 2, but mostly due to sudden cardiac death. And ejection fractions also commonly used to predict heart failure patients' outcome. Yes, patients with the low ejection fractions tend to have a higher risk of death, either because of ventricular arrhythmia or pump failure. But it's not that simple in heart failure patients. Most of heart failure patients have more than one comorbidities that may strongly impact the patient's outcome. Thus, we cannot only rely on ejection fractions or functional capacity. Moreover, these data show us a fascinating fact that the evolving of heart failure treatment has a huge impact to heart failure outcome. The mortality number of heart failure patients is getting lower, especially related to the sudden cardiac death. That's why, for say, the role of prognostic risk score will become increasingly relevant nowadays, considering that the annual rate of cardiac death, especially related to the sudden cardiac death, has been significantly falling over the past 20 years with a comprehensive heart failure treatment. Therefore, we need a better prognostic tools considering the risk of death in heart failure patients are beyond ejection fractions and NYHA. Guidelines also recommended the use of prognostic risk score to predict heart failure outcome. ESC 2016 stated prognostic risk score will help to decide on the appropriate type and timing of therapies, such as decisions about rapid transitions to advanced therapies. ACC 2013 also put prognostic risk scoring as a class 2A recommendations to estimate subsequent risk of mortality that may guide for therapeutic decisions making. Canadian Cardiovascular Society in 2017 guidelines also stated to incorporate this scoring system into our clinical practice and use to convey risk to patients and family. And if we learn from the Paradigm HF study, although most of the patients were NYHA class 2 and have a good background of heart failure therapy, but many remain at substantial risk of death and adverse outcome. This shows us that there is a poor correlation between reported functional capacity and prognosis in heart failure. That's why we need a better risk stratifications beyond functional capacity that will help us define patients that can get more benefit if we initiate certain medications. As we can see in here in this graphic, patients with a higher risk score, although in the same NYHA, will get more benefit with sacubitril valsartan. Thus, yes, we need risk score in heart failure for a better risk stratifications for a group of patients that will get more benefit from initiating certain medications and to decide the appropriateness and timing for certain heart failure treatment or rapid transitions to advanced heart failure treatment. So the take-home message for my presentation today is risk score in heart failure. There are many risk score in heart failure, but none show a clear superiority. However, biomarkers give a better refined risk of death. Therefore, we should use biomarker to predict heart failure outcome on top of other clinical variables. And if you go back to the first questions, risk score in heart failure, are they useful? The answer will be yes. It is useful for a better risk stratifications for optimizing medical treatment, especially to avoid misconstrued stable symptom as a low risk. Then it gives justification for clinician not to escalate GDMT, and at the end, the patients will not get an optimizing medical treatment. And then yes, it's useful for adequately characterize the overall risk of heart failure patients and to convey truthful information to the patient itself and also her or his family members. And also it's very useful for helping us to decide on the appropriateness and timing for devices or rapid transitions to advanced heart failure treatment. Thank you, and I will be glad to take the questions.
Thank you very much, Professor Sasmaya. You took a very difficult and very controversial task to enlighten us on the risk scores in heart failure, and I may say that you did a great job. And let's see what the question will be like at the end, because I assume that it will be a lot of questions. Now, ladies and gentlemen, we are going to proceed on the fourth lecture of our meeting. This lecture is going to be given by one of the most prominent Singapore cardiologists, Julian Loch. Julian will address the management of acute heart failure. As you all know, this is also one of the dark spots of the brilliant sky of the heart failure, because we experienced many failures in the last 10 years in testing different drugs for acute heart failure. So, Dr. Loch, we are looking forward to hearing your question. Please.
Good afternoon, everybody, and hello from Singapore. My name is Julian. Thank you very much to the organizers for the kind invite to give this talk. What I aim to cover over the next 15 minutes or so is to kind of take us through the ESC guidelines that were published this year pertaining to the section on the management of acute heart failure. This is a section that doesn't really have many or any positive trials, so most of the level of evidence is going to be levels B and C. So the four major updates that I hope to go through during this time is a revision or a refinement of the definitions, 2, a return back to the clinical profiles that we see in acute heart failure, 3, a section on the assessment of diuretic response, and 4, the de-emphasis on vasodilators in the management of acute heart failure. So first to definitions, and the definition of acute heart failure has been relatively consistent over the last few years from 2005 to 2016. All have in common a rapid onset of symptoms, which is of a life-threatening condition that requires urgent hospitalization or urgent admission, and can either be a de novo presentation or more commonly an acute decompensation of a chronic heart failure. So there are two small refinements to the definition of acute heart failure this year. The first is that it can either be a rapid or gradual onset of symptoms. The second change is that it doesn't require a hospital admission. Any urgent medical attention leading to an ED visit and therapy with IV diuretics also counts as well. The reason for this really is because the guideline committee felt that the onset of symptoms could be gradual, there could be progressive fluid overload, and second, heart failure is really a multi-event disease, and there are differing risk appetites and thresholds for admission. And again, they stated that this can either be an indexed de novo presentation, but the majority of them tend to be decompensation of chronic heart failure events. In terms of epidemiology, acute heart failure is the leading cause of hospitalization in adults more than 65 years of age. It is associated with high mortality and high rehospitalization rates. Index presentations tend to have higher mortality but lower rehospitalization rates. So on this slide, we see the flow charts for the diagnosis on the left and the management of the right of acute heart failure, and as much as possible the diagnosis and the treatment should really proceed in parallel. On the left, for diagnosis, we go on with a history and physical exam. Some relevant investigations are suggested, and we go on with natriuretic peptide testing. The BNP, of course, is a very sensitive test with good negative predictive value. NT-proBNP is preferred, and NT-proBNP value of less than 300, of course, has a negative predictive value of about 98%. On the right, with regards to management, there is a update from the 2016 guidelines. For acute life-threatening etiologies, the acronym used to be CHAMP, which was acute coronary syndrome, hypertension, arrhythmias, mechanical complications, and pulmonary embolism. this has been expanded to include infections and tamponade as well in these guidelines. So 2 extra acute life-threatening etiologies that should be screened for. So this is an expansion of the investigations that could be considered, as well as the degree of indication, which is the final column on the right. So the clinical profiles that we encounter in acute heart failure have made a comeback this year after being relatively de-emphasized in the last 2 guidelines. So the first time that these clinical presentations were described were in the ESC 2005 acute heart failure guidelines, and they attempted to classify them based on 6 presentations. The first was acute decompensated heart failure. The second was hypertensive heart failure. The third was acute pulmonary edema. The fourth was cardiogenic shock. The fifth was high output cardiac failure. And the sixth was RV failure. In 2008, the heart failure guidelines kept to the 6 presentations, but refined it somewhat and changed high output cardiac failure to acute coronary syndrome with heart failure. In the ESC 2012 and 2016 guidelines, the clinical profiles appeared to be de-emphasized, so I was a bit surprised to see it make a comeback this year. This year there are 4 clinical profiles that are highlighted. The first is acute decompensated failure, the second is acute pulmonary edema, the third is isolated RV failure, and the fourth is cardiogenic shock. Acute decompensated heart failure is by far the most common and estimated to be 50 to 70% of presentations. The patient normally has a history of heart failure, and like acute pulmonary edema, there tends to be a more gradual onset. Systemic congestion is the main problem, and so the objectives of treatment is to identify the precipitants, to decongest the patient, and to correct any hypoperfusion if it is present. Acute pulmonary edema, as we mentioned, tends to have a slightly more rapid onset. It is related specifically to lung congestion, and is therefore managed with PEEP, either with non-invasive ventilation or with high-flow nasal cannula. We decongest with IV diuretics, and IV vasodilators may be necessary to reduce LV afterload. For RV failure, the first line is diuretics, and cardiogenic shock is, of course, the most extreme expression of acute heart failure and is a life-threatening condition. And for the first time this year, specific treatment algorithms have been proposed for each of the clinical profiles. So a lot of thought has been put into this. I must admit, though, I struggle sometimes because, as we know, the clinical profiles can overlap. So you can have a patient with acute decompensated heart failure with a relatively quick onset of symptoms and who is in pulmonary edema, and you sort of wonder which treatment algorithm you follow. So that was something that I found slightly confusing from the guidelines this year. With regards to cardiogenic shock, there was an emphasis that low blood pressure is no longer part of the definition, as hypoperfusion can occur with a preserved blood pressure. This is what we term normotensive shock. And we, of course, know that in a patient with, for example, a set ejection fraction, the patient with a normotensive shock tends to do better or have a better outcome than a patient with hypotensive shock. So these are the ESC 2016 heart failure guidelines recommended approach to acute heart failure. And I must say that as a practicing clinician, I find these recommendations slightly easier and intuitive to follow. You know, you assess 3 main clinical parameters. You assess backward failure and congestion, you assess forward failure and perfusion, and you assess the blood pressure. And based on these 3 parameters, you sort of make a plan on how you approach the patient. But I do understand that, you know, classification systems are good and they're important, and they drive research and data to help us understand disease conditions better. But from a clinical practice perspective, I do find the 2016 guidelines slightly easier to follow, and I would be grateful for the thoughts of the other members of the panel with regard to this. With regards to oxygen and ventilatory support, it's very intuitive, and there's not much change from the guidelines in 2016. For the diuretics, there is a new recommendation on what is deemed a satisfactory response to your loop diuretic, and that is a urinary spot sodium of more than 50 to 70 about 2 hours after the IV Lasix dose is served. If not, you can assess the urine output for up to after 6 hours, and it has to be about 100 to 150 mils per hour. Otherwise, the dose of Lasix is the same. In a Lasix naive individual, it's about 20 to 40 milligrams of IV Lasix BD or TDS. If the patient does have a baseline loop diuretic, we recommend that you're given 1 to 2 times the daily oral Lasix dose. It is recommended to give at least a BD to TDS dose to avoid post-dosing sodium retention that can occur with once daily dosing. So the recommendation is that if the response is satisfactory, that's good. If it's unsatisfactory, you double the loop diuretic dose. And if it still remains unsatisfactory, you then pursue sequential blockade with either metolazone, thiazide, or acetazolamide to block the sodium chloride reabsorption downstream. And just to be careful with monitoring the UE when you do that. And the reason for that, of course, is because there's a very steep dose response curve with plateaus at common doses, leading to a ceiling effect. Moving on to inodilators and vasopressors, the 2016 guidelines are on the left and the 2021 guidelines are on the right. And the main change that we see is a downgrading of the recommendation for vasodilators from class 2A to class 2B. So this is on the back of the Galactic study and the Elizabeth trial, which failed to show benefit of vasodilators in acute heart failure. And this is consistent with a lot of numerous trials that have failed to show benefit for vasodilators. So it's been downgraded to class 2B. For inopressors, we prefer noradrenaline over adrenaline due to the Optima CC trial. This was a very small trial of 57 patients with AMI with cardiogenic shock, and there was a higher rate of refractory shock in the epinephrine group of 37% versus 7%, and the trial was terminated prematurely. And we saw that the patients with adrenaline and much higher heart rates and 3 times higher risk of death, and so noradrenaline is preferred. Noradrenaline is also preferred over dopamine based on a subgroup analysis of 280 cardiogenic shock patients in the SOAP2 trial. With regards to inodilators for dobutamine and milrinone, the DO-RE-MI study suggests similarities and no difference in outcome for dobutamine versus milrinone in cardiogenic shock. So the definition of cardiogenic shock has always been a problem because there have always been many different definitions. So the Society of Coronary Angiography and Intervention has attempted to harmonize and propose a standardized definition of cardiogenic shock, which is what you see on the left. With regards to mechanical circulatory support and IABP, they have a class 2A and class 2B recommendation respectively. Based on the IABP SHOCK2 trial, IABP is not routinely recommended in post-MI patients in cardiogenic shock. So this is very sobering data, but this is a meta-analysis of mechanical circulatory support versus IABP. And what we see here is that despite the mechanical circulatory support achieving better hemodynamic parameters, such as mean arterial pressure, cardiac index, wedge pressure, and better perfusion parameters such as a lower arterial blood lactate, the mortality is exactly the same. So there is this dissociation between hemodynamics and improving outcome. And this is not a one-off. We saw this in the SHOCK trial as well. So this makes things a real challenge for us. Last 2 drugs, thromboprophylaxis is the only recommendation that carries a level of evidence class A. And so thromboprophylaxis is recommended in patients with acute heart failure. In Asia, we tend to feel our patients don't have as many DVTs as our colleagues in the West. So not something that we do in our practice too much in Singapore. With regards to the routine use of opiates, this is not recommended based on 3 propensity match analysis linking morphine to high mortality. But of course, opiates can be used cautiously to relieve dyspnea and anxiety, and this is the doctrine of double effect. Some recommendations are made for the pre-discharge phase. So very intuitive. The first is that the patients are properly decongested before discharge. The second is that guideline-directed medical therapy is initiated appropriately, and this is a good window of opportunity to do so. The third I find a bit more difficult to comply with, and that is to get an early follow-up 1 to 2 weeks after discharge. And finally, do take the chance to administer ferric carboxymaltose for those with functional and absolute iron deficiency. So in summary, we've run through the new updates to the ESC 2021 acute heart failure guidelines. We've looked at the refined definition of acute heart failure, the return of the clinical profiles in AHF with management algorithms. We've looked at the assessment of diuretic response and the de-emphasis on the use of vasodilators for acute heart failure. With that, I'd like to thank you for your attention, and I look forward to the discussion. Thank you very much.
Okay. Let's start the discussion. Let's first. Okay. So could we see each other and could we hear each other?
Yep,
Yes.
I think we can hear.
Yes, I can
Okay,
hear your
excellent.
voice.
Excellent. So let me find where is the pin. We need to find the pin. Okay. So we had 4 excellent lectures, and Dr. Azmee and me will try to go ahead with the lecture, with the questions. Obviously, these were all controversial topics. We may say controversial, but also very important. And first of all, can I start, Dr. Azmee?
Yes, we can.
Okay. So I would like to ask Professor Komajida one important thing in the past regarding the HFpEF were the comorbidities. And we know that the comorbidities were the main stem treatment strategies of treating HFpEF. Would you please, Professor Komajida, comment between the relations of the major comorbidities in HFpEF, diabetes, for instance, and the treatment results we got from Emperor Preserved? Because do you think that there are any relations between anti-diabetic effect of the SGLT2 inhibitors and positive effect we have in this trial, although we know that these patients were not diabetic?
Thank you, Petar. Yeah, so thank you for this important question. Actually, I have to be honest and say that the mechanism of action of SGLT2 inhibitors in both HFrEF and in HFpEF remains largely unknown. Now, you made a very important point to say that until we got the results of Emperor Preserved, the main strategy of treatment of HFpEF was to try to treat the underlying disease. I mean, in most instances, hypertension, and in many patients, diabetes mellitus. So now we have a new option which proved to be beneficial in HFpEF, which is empagliflozin, and we will know soon if dapagliflozin is also beneficial, because we are expecting the results of a twin trial, if I may say so, which is delivered next year probably. And so we will know whether it's a class effect or a drug effect. Having said that, you could notice that the benefit was very similar in diabetic and in non-diabetic patients. So I think this is quite an indirect proof, but I think that the anti-diabetic effect is probably not the driving force explaining why empagliflozin was beneficial in HFpEF. There are several mechanisms which have been discussed, including an anti-inflammatory effect, lowering the weight, lowering slightly blood pressure, also a direct myocardial effect, but none of these effects has really been convincingly demonstrated in the clinical setting.
Thank you very much. Just one more thing to add to our viewers. It will be very important. We know that there are some other drugs besides diuretics which are releasing the congestion in the treatment of HFpEF, which are not, as you said, convincingly positive. Do you think that any of those drugs can be add on to the empagliflozin in trying to improve the status of this patient? I am referring on the first place on sacubitril/valsartan.
Yes, thank you very much. So one, I think that the diuretic effect which is observed with SGLT2 inhibitors is really transient, and it usually disappears after a few days. So it cannot explain the benefit. Now, your important question is how to combine empagliflozin with other heart failure drugs. And actually the beauty is that it's a very well tolerated class of drugs with little effect on blood pressure in particular. So I think that we can safely combine this drug together with other heart failure medications. And as you said, it can be combined with sacubitril/valsartan because these are two different pathways, and actually it seems that the rate of side effects is quite similar in patients treated with both empagliflozin and sacubitril/valsartan, and so I think it's quite an easy drug to use in clinical practice.
Thank you very much, Dr. Azmee.
Yeah, Professor, I'm just wondering, with the guidelines in heart failure with preserve, of course, SGLT2 inhibitor has not been included yet. So, will there be any update or any update in guidelines? And I think that will help the majority of our doctors in terms of using this, because at the moment we do know that it's working, helps with our patient, but it's not in the guidelines. So it's quite difficult for, for doctors to use it.
Yeah, I think as alluded to by Professor Seferovic, it was only a matter of timing, and it's a bit unfortunate, but when the heart failure guidelines were released, Emperor Preserve was not yet available. Actually, it was released the day after. So I am pretty sure that there will be a sort of amendment made, because it's really a landmark trial. And as I said, it's the first time we have one clinical trial which is definitely positive in this setting. So I am pretty sure that ESC and particularly Heart Failure Association will make an amendment in order to put this drug in the current version of our guidelines.
Yeah. I have one question to Dr. Sasmaya. I think,
Yes.
you mentioned about the, all these risk scores, and I think we do it, we use it in the context of advanced heart failure, considering for transplant and LVAD, looking at the risk scores. But in general, in your clinical practice, which one do you actually use, and which one, among the ones that you presented, functionally very well in general heart failure population?
Yeah. Actually, it's quite difficult for me to answer your questions, and it's very good questions, actually. It's quite challenging for me to make the presentations at first. So yes, actually, to be honest, I usually use the Seattle or Magic Risk Score, considering that it's very easy for us to use, right? We just downloaded the calculator, and then we just use this calculator. But the main problem is, as I already mentioned in my presentations, that Seattle and also Magic Risk Score, they developed in the very early beginning of the year 2000s, right? So at that moment, we haven't implement the four pillar of the heart failure treatment, either the ARNI or the SGLT2 inhibitor. So I'm not sure whether we still can use this risk score in our daily practice now. So that's why I tried to find, is there any new heart failure risk scores in heart failure? And turns out there's two new risk scores in heart failure, which is the Predict HF and also the Emperor Reduced risk score. That they, as we know, that this is those two risk score developed based on the Paradigm HF study, and also based on the Emperor Reduced study, that we know that both of these studies included patients with optimizing medical treatment and already used the four pillar of heart failure treatment. So probably after making these presentations, I will use the Predict HF risk score and also Emperor Reduced risk score. I probably try to use these scoring systems to
Do you agree that, Prof. Seferovic?
Yes, that's why I also wanted
yeah,
to.
I think what is your opinion?
Yes, what is your opinion? Because it's quite difficult for me, actually, to be honest.
Okay, so our last question go to Dr. Loch, which underline an excellent approach to acute heart failure, and this is always asking question, Dr. Loch, and this is the role of vasodilators in the treatment of heart failure, acute heart failure, because one of the most unsuccessful clinical trials in acute heart failure were with vasodilators, with relaxin, and with uleratide. So could you tell us what's the place of you underlined that to some extent, but in the recent clinical practice updates, vasodilators were again put forward as one of the most important therapeutic options. Could you please comment on this?
Yeah, so thank you very much. It's a very frustrating question. It's a very difficult to tackle. So put it this way, our classical teaching has always taught us that when the heart fails, there's a compensatory systemic vasoconstriction. And this systemic vasoconstriction then, the systemic vasoconstriction helps with the cardiac output. But what we see is not necessary, we don't necessarily see that all the time. And for example, in the shock trials with Dr. Judith Hoffman, we saw that 20% of the patients were actually vasodilated on presentation. And this is MI with cardiogenic shock. And despite the use of presses, the average SPR was actually about 1,003. So they weren't that vasoconstricted. And if you consider patients with acute decompensated heart failure, and these guys who are a very different cohort from the AMI patients, there are upregulation of like vasoconstrictors like AT2, endothelin 1, and noradrenaline, and things like that. So the first thing I'd say is if a person comes in cardiogenic shock, whether it's decompensated heart failure or myocardial infarction with cardiogenic shock, you cannot assume to know what the peripheral resistance is going to be. And unfortunately, there seems to have been a de-emphasis of the Swan-Ganz catheter. But in our intensive care unit, we rely on the Swan-Ganz a lot to guide us. There is a lot of confusing literature for the intensive care. If you follow Professor Paul Merrick and the intensive care guys, they will tell you the AUC of a CVP or an AUC of a Swan-Ganz is 0.5. It's like flipping a coin. Or as Professor Paul Merrick says, it's like checking the color of your toenails to decide what to do with the vasopressors or the inodilators. But we use it a lot in our practice to guide us. I do believe that there's a role of vasodilatation in cardiogenic shock, especially in patients with acute decompensated heart failure, because we know it is one of the pillars of treatment in decompensated heart failure. It's inotropy, it's vasodilatation, and it's decongestion, because the failing left ventricle, understanding pressure volume loops, is very afterload sensitive.
Thank you very much, Dr. Loch. Now we intend to close the session because it's already the time to conclude. And I would like to give my part of the conclusion, saying that we tackle the most important and the most up-to-date topics in cardiology. And I would like to thank you once again to all speakers, Professor Komajda, Professor Sasmaya, and Professor Loch. I think both the lectures and discussion were highlighting what is important in both chronic and acute heart failure. Now, I would like to ask my co-chair, Dr. Azmee, to conclude the session.
Yep. Thank you very much, all speakers. I think it has been an excellent talk, and I think we've heard about the update. We heard about managing and treatment of heart failure with PRESERVE. We look at risk score, and we look at acute heart failure. I think it's a complete, and I think it's been a great session, combination with ASEAN and of course the way the European Society of Cardiology. Thank you very much, everyone, for tuning in, and hope we can meet soon, virtually or physically. Thank you very much.
Thank you all.
Okay, have a nice afternoon. Have a nice day.
Thank you all. Bye-bye.
Bye-bye.
Have a nice day.